Hi, welcome to our program. Tonight, we're going to be discussing leveling up on the treatment of dry eye disease, part one of a two-part series. My name is Kendall Donaldson, and I'm a professor of clinical ophthalmology at the Bascom Palmer Eye Institute. I practice cornea, cataract, and refractive surgery in Miami, Florida. And here are my disclosures. And I'd like to introduce my associate and co-moderator this evening, Justin.
Hey, Kendall, really excited to be here with you tonight and looking forward to the discussion around, dry eye disease. My name is Justin Schweitzer. I'm an optometrist at Vance Thompson Vision in Sioux Falls, South Dakota. We're an MD-OD collaborative care practice focused on cataract, cornea, refractive, and glaucoma. And my financial disclosures are on the next slide here. And I'm looking forward to us jumping into what we're going to be talking about tonight, which is very case-based and hopefully will allow a lot of our listeners to be able to take some things back to their clinics the next day after they've listened to us.
Terrific. Thanks, Justin. All right. This educational activity is provided by Medicus and supported through an educational grant from Bausch and Lomb. Just a little about our CME information. Medicus is accredited with commendation by the Accreditation Council for Continuing Medical Education. This is worth 0.5 AMA PRA Category 1 credits, and we should claim only the credit commensurate with the extent of our participation in this activity, please. Here's your C information and our learning objectives for the evening. After completing this activity, participants will be better able to review the function of the tear film and maintaining a healthy ocular surface, incorporate diagnostic strategies that lead to targeted treatment of dry eye disease, and review clinical evidence of approved treatments for dry eye disease. Off-label discussion, we may include some discussion of unlabeled or off-label or investigational uses of drugs or devices. Please refer to official prescribing information for each drug or device discussed for appropriate dosing, indications, and warnings. So I'd like to begin with a case from my clinic, and I'm looking forward to hearing your commentary tonight, Justin, on this case, which has been a challenging case of a patient that I've followed for the last several years. So I wanted to talk a little bit about preservatives and alternatives to preserved medications in our practice. So this is the case of a 66-year-old gentleman with a history of 3 years of a red right eye. He's a patient that I share with one of my glaucoma colleagues. He has a 15-year history of open-angle glaucoma. He has pretty severe cupping. He's undergone an Ahmed valve placement in the right eye. He's also had cataract surgery in the right eye in 2018. And this was followed with corneal decompensation. So he struggled with a pseudophakic bullous keratopathy, and certainly that valve wasn't helpful in the anterior chamber either. So he even developed aqueous misdirection, which required a pars plana vitrectomy in the right eye. In 2019, my colleague and I did a combined surgery where we repositioned the tube posteriorly, and we also did a DSEC surgery at the same time in the right eye to help with the corneal edema. And of course, he had to develop cystoid macular edema postoperatively after all this surgery. And so he also was followed by our retina colleagues. So not a simple right eye there. The left eye, fortunately, was a bit easier. He had a cataract there, but wasn't visually significant. And here is his slit lamp examination. You can see he had a little bit of scleral show. His lids were a little bit out of position in that right eye after all the surgery. So he had a little ptosis, a little lower lid lag, and some exposure keratopathy there. His graft was clear. I'll show you a slit lamp photo in just a moment. But fortunately, his DSEC remained clear. He had a diffuse punctate epitheliopathy, but not a frank epithelial defect. And he had his posterior chamber dryer lens there. You can see he was also very cupped actually in both eyes. So he had significantly more injection in the right eye. He had a little injection in the left eye, but everything in the left eye looked much quieter. You can see his vision overall was pretty good, a little prism there, a little strabismus. So you can see here his right eye. You can see the inferior scleral show and that lower lid that's just has a little inferior lid laxity there. And you can see the diffuse epitheliopathy in the right eye. He also had a lot of MGD, inspissated glands there that you see as well. And then in the left eye, a mild keratitis as well. So here's his medication history. You can see in that right eye, As I mentioned, he's been treated by our cornea service, our glaucoma service, and our retinal service, and we've all added a couple drops along the way here. The ketorolac was for the retina service to help with that CME. The prednisolone was for his cornea as well as the posterior segment, and then all of the glaucoma medications as well, really stacked up in that right eye. So here we have his topography. We can see some hot spots there in the central 3 millimeters in his visual axis in the right eye. He did have some irregularities in the left eye as well, as you could see here. So I wanted to start with a question for all of our listeners, as well as for Justin and I to discuss a little bit here. So what is the most appropriate first line of treatment for a patient like this? A, should we increase the frequency of the steroid drop to try to quiet the eye down? B, perform a conjunctival resection. A lot of times these patients have conjunctival cholesis, and so that's one option. A C, treat as an allergic conjunctivitis, maybe add a mast cell stabilizer. D, consider a compounded combination preservative-free glaucoma drop. Or E, red eyes are just inevitable in patients with glaucoma, so this is really pretty normal. So Justin, I know you follow a lot of these patients as well, and it's really a challenge, isn't it?
Yeah, these are challenging patients. You know, a couple of things come to mind. My first thought is we got to reduce his drop burden somehow, in some way. And I love the idea of preservative-free glaucoma medication. So D jumped out at me right away when you showed this. Increasing the frequency of the steroid, I think, is reasonable. He has a tube. It's a glaucoma patient, so we need to be careful with that. And so I think A is reasonable. I don't like E. He's there for help, and so we can't just speak to him. It's inevitable. And a couple other things that come to mind. Unfortunately, with this patient, this wouldn't work. But a lot of times, what I do is I think of drug delivery. There's a drug delivery pellet out there called Bimatoprost SR that I can give people a drop holiday from, give them a break from their drops. We're still getting treatment because it's injected. It's placed inside the eye. The contraindication, though, for it is anyone that's had a cornea transplant. And so in this particular patient, we wouldn't be able to do it. So I'm kind of moving towards D, Kendall.
Yeah, no, I absolutely agree. And that's exactly what we did, Justin. Yeah, I always worry about bumping up the steroids when I can see that his tube is not really adequately controlling his pressure, because in addition to that tube, he's got all these other drops on there. So she was really having trouble controlling his pressure, even with the tube. So, yeah, so these are tough patients. Fortunately, we have compounding pharmacies that can put all of those glaucoma medications into one. So they can have like 3 different glaucoma medications in one. It's preservative free. And actually, it's pretty reasonably priced as well. So yeah, we did end up doing that with this patient. So, so just a couple comments on preservatives in eye drops. Of course, they maintain sterility and they can extend shelf life, but certainly they can be difficult for the ocular surface. And we know that benzalkonium chloride is the most common preservative, and it's found in 70% of our ophthalmic drops, and it is cytotoxic and can significantly worsen ocular surface disease, as we see in our practices every day. Fortunately, there are some less cytotoxic preservatives that do exist out there. They're not as commonly used. And we do have all of these different preservative-free options for patients now, more and more all the time, thanks to the companies working with us. However, they come with higher cost, availability may be limited, and there can be risks of microbial contamination when we get rid of those preservatives. So back to our patient real briefly. We did perform corneal sensitivity testing, and it was depressed. And I was trying to avoid adding more things and wanted to take away, like we were saying before, Justin. So we did gradually attempt to decrease the drops. The first thing we did was get rid of the nonsteroidal. We did talk to our retinal service before doing that, and we did a trial off of it. And actually, his retinal thickness remained stable as we got rid of the NSAID. So sometimes, they maybe really don't need that. They've just been on it for such a long time, but he actually did much better without it. And then we did switch him to preservative-free tears as well. We talked about snudgemin, but we never ended up needing it after all. But we did use the combo drop. And now they don't have the latanoprost in the combo drop anymore, so you have to use that separately. But at that time, we did have the quad combo drop available, and he really has done quite well. So wanted to end with one more question. Patients with glaucoma are often victims of medicamentosa resulting in MGD. So which of the following lessons is important in the care of these patients? A, consider switching to preservative-free medication alternatives. B, consider using laser procedures or minimally invasive glaucoma surgery to help reduce the drop burden. C, they may need low dose steroids to reduce redness at times. D, consider stopping the nonsteroidals if possible. E, consider checking corneal sensation. And F, all of the above. Justin, this is a tough one, right?
I'm going F. I'm going F on this one.
Good job. Good job. All right. I absolutely agree. All right. Why don't we move on to your case? I know you have a great case to share.
That was fun. That case you presented is like my daily life, I feel like,
I
in my
know.
practice
I
is
feel that way
managing those
too.
things. So that was a perfect way to start this off. So I appreciate you doing that for me. I feel like you did that just for me to get things rolling.
Just for
So
you, of course.
thank you.
Mhm.
Well, case two. So this is a patient. We'll jump right into that. Had a lot of fluctuating vision, dryness, irritation, and everything we would see with someone that has ocular surface disease. But we have such good tools now in different management ways, diagnostic ways, treatment options, and so we're going to see what you think here, Kendall, on how you would manage this patient. Would you have done it differently than I would have? And that's kind of the beauty of doing cases, is that there's probably not a wrong way to do it. There's just different nuances the way that you manage and we manage patients. So
Well, I do think we're lucky to have options nowadays, you know?
very lucky, and new options too. And we're going to touch on some of those here in a little bit as we get through into these cases. So this was a patient that struggled with dryness, irritation, burning eyes. Really had never done eye drops before, 61 years old. And, when I see fluctuating vision, which she complained about, the first thing I think about is obviously the ocular surface, the tear film. There can be other things, but that definitely has to be one of the tops in my differentials. Also that it got worse as the day went on. So she spends a ton of time on a computer and a tablet. So she's not blinking. Her blink rate is not as high. Does not smoke, doesn't run a ceiling fan, is not either or eye rubber either. Some of the common questions that I like to ask patients. When we look at the rest of her history here, nothing really jumps out at me necessarily. Family history of age-related macular degeneration with her grandmother. So here's an examination. All our patients that come in for evaluations, whether it's cataract, glaucoma, refractive, whatever it may be, they take a speed questionnaire. I like to have that information. Number one, it triggers my technicians to get additional testing for me. But number two, it's good to start a conversation with my patient around some of their symptoms and what's bothering their eyes. And so you can see here the speed score was 10 out of 28. I tell my technicians if it's 6 or above, go ahead and get me some point of care testing. And you can see those point of care tests we've got here, which is MMP9, as well as the osmolarity test. We'll touch a little bit more on that a little bit, but both of those being abnormal, pressure, good vision, reduced a little bit. You can see in the slit lamp here that this patient has, some central, punctate epithelial erosions, peripheral as well on the images there. Tear breakup time less than 5. Lids and lashes, I'm kind of jumping around here. The meibum, I always say, as long as you have a digit, you're going to be able to examine the meibomian glands. You can press on the glands and take a look at what do those secretions look like. And they were slightly opaque with this kind of low tear meniscus. Posterior segment exam was unremarkable for this particular patient. So really a lot going on with the lids, a lot going on with the cornea as well. And then those positive, point of care tests pointing us in the direction this patient is really suffering. How do we make her better? And then we can see, the meibomian glands. I talked about the substance, the opaqueness of the meibum, but the meibography here gives us some idea of what's going on with the structure. And it's not a perfect image. It's not a great image here, but it's enough to show that there's definitely some issues with the structure of the meibomian glands as well. And we're going to touch on this a little bit more as we get into some other images. And I'd love to get your thoughts on that as well here in a second, Kendall. So question 3, tear film osmolarity results are considered abnormal when they are A, greater than or equal to 308 or greater than 8 difference between eyes. B, greater than or equal to 308 and greater than 8 difference between eyes. C, greater than 280 and greater than 8 difference between between the eyes. And then D, between 280 to 295. And so we're just kind of reviewing point of care testing in regards to tear film osmolarity. Kendall, what do you think?
I would have to say A, greater than 308 or more than 8 milliosmol difference between the eyes.
And of course, you're correct. That is accurate.
Yeah, Justin, I always find that I have to use this in conjunction with another test like MMP9 because sometimes you can have some variability, and I think that's part of the hallmark of ocular surface disease. One day they can be worse, and another day they can be better. There's just a lot of variability. So I have a hard time using osmolarity alone, but I like the way you also mentioned that your patient's MMP9 was positive too. So I like to do those two tests together and kind of put it all together for a bigger picture. So I like the way you and you use the speed questionnaire. A lot of times we use the OSDI, but I think either of those can be helpful to get symptoms. Yeah.
Yeah, I completely agree with you. It's a puzzle, right? If we just use one test, it's going to lead us astray in treatment and diagnosis. And this test is great, but it's just a small piece of the puzzle of our diagnostic, armamentarium that we have in front of us. This is just an overview of what happens in dry eye disease. The hallmark really is inflammation and a disruption in the homeostasis. And everyone's fairly familiar with this, but we have those three components of the tear film that are kind of intermixed with one another. You have the mucin component, you have the aqueous component making up the bulk of the tear film, and then that lipid layer as well. So I'm not going to spend a lot of time on this. This is more review, but just keep in mind two hallmarks: inflammation and disruption of homeostasis of that particular tear film. And I do like this slide because it really looks at those treatment options that Kendall mentioned earlier. It talks about, what are our different therapies? What are some of these new innovations? And if you look at this particular slide, we have our, gland probing heat-based interventions, IPL, which is our in-office therapies, which have been a really nice addition to treatment options for our patients with evaporative dry eye. We also have our corticosteroids or immunomodulators to manage that inflammation, one of the hallmarks of ocular surface disease. Fatty acid supplementation. So nutraceuticals important again to manage things like evaporative dry eye. You move to the other side here, lid hygiene, lid debridement. We're going to talk a little bit about managing blepharitis here in a little bit. And then finally, we've had some innovations even in tear evaporation treatments. We're going to touch here a little bit on perfluorohexyloctane, a new medication that recently entered the market to help our patients with evaporative dry eye. So I think this slide kind of covers all the different treatment options that we utilize in a variety of different ways to manage our patients with ocular surface disease. So in my patient, this was the 6-week follow-up in the intervention that I did. So I did some heating and gland clearing. I'm going to show you that video here in a second. I did start a topical corticosteroid, and I almost always do that after I do any in-office gland clearing procedure, whether it be thermal pulsation or heat and gland clearing or even IPL. We're going to go ahead and I usually want to make sure I'm calming down any inflammation that I've kind of stirred up on the ocular surface. I then also, for maintenance and continued therapy, prescribed perfluorohexyloctane, which we'll touch on here in a little bit, 4 times a day. And then at that 6-week follow-up, a lot of times after I've calmed down the inflammation, the patient has had some time to let that treatment all set in. I will, especially if the cornea has some punctate epithelial erosions, place some punctal plugs just to kind of keep those healthy tears on the surface of the eye. Kendall, anything else that you would add here or do differently even?
Yeah, I mean, I love the way you treated this patient. It makes total sense. I think that's a great point that you made. A lot of people will jump to plugs, but I like the way you treated the inflammation first, express the glands first, and then put the punctal plugs later. So I think that's great. So I think this sounds great. I always use loteprednol after my procedures in the office. I usually do it 3 times a day just for 3 days, but now you have me thinking about doing it longer. But yeah, so I always use a short course of the steroids right after a procedure. And then, of course, we have some limited exposure to perfluorohexyloctane. So that's been great over the last few months, having that as another agent to help these patients as well. So yeah, this sounds like a great course. So how's she doing?
She's doing really well, and when you see this gland clearing video in a second here, it's probably one of the most satisfying feelings when you're getting all that gunk out of her glands and you're making an impact. But yeah, the patient's doing much, much better. We'll show the conclusion here in a little bit. Really quickly, I'd love your thoughts on this too, Kendall. Perfluorohexyloctane is this new medication that we have on the market, really meant to manage our patients with dry eye syndrome, both the signs and symptoms. We'll look at some data around it. What's unique about it is this is a water-free, preservative-free drop. It's 100% perfluorohexyloctane. And so this particular drop doesn't have a pH to it. You don't have to worry about a preservative because it's water-free, so you don't have to worry about, microbials getting, into the bottle or or contaminating anything. And it's unique how it coats the surface of the eye because of the molecule, the way that it's set up. It's got this lipophilic component to it, which kind of wants to sit in the lipid layer, and then this more aerophilic component that wants to be to the air. And so the molecule sits in one particular orientation at all time because it's reaching for the air and reaching for the lipid. And it creates this nice monolayer across the cornea to really help with evaporative dry eye situations. And that's really where I've typically utilized. And I think the other major bullet point here to point out, and yes, it's based on a rabbit model, but it remained in the tears for up to 6 hours. And when we think about our traditional artificial tears, they remain in the tear film maybe 4 to 5 minutes, 5 to 10 minutes. And so just the longevity of this is nice as well. Anything to add to that? Has your experience been good with this particular drop?
Yeah, and it's actually really well tolerated. I think it's just so unique, as you mentioned. It sort of creates a meshwork, a protective meshwork over the surface of the eye. Patients really like the way it feels. It's kind of refreshing and silky, feeling. So, it's very comforting and very well tolerated. And it is, unique in the way that it is an inhibitor of evaporation. We don't really have anything that targets evaporation, as you mentioned, Justin. So it's a really unique mechanism. And I think it can be used alone, or it can be used in conjunction with all of these other, things that we have available to patients. And so it can work along with those other agents as well. So,
And the data around it, looking at both signs and symptoms, is really good. We look at first on the left side over there, total, corneal fluorescein staining. We're looking at this at 8 weeks and change from baseline. And these particular patients, their total fluorescein corneal staining score was 6.9. That was the mean or the average if you combine both phase 3 clinical trials, which is what we're looking at here. And the way that these numbers are brought up is the cornea has 5 sections to it. Each section can score a level. The highest it can score is 3 on a staining score. With the 5 sections, the highest you could score is 15. 5 times 3, 15 is the highest. Again, on average, they were 6.9. And you can see about a 2 improvement in one of the phase 3, about 2.3 in the other. And I think a key point to bring up too with this total corneal fluorescein staining is in order to be even in the study, their total corneal fluorescein score had to be 4 or above. And so you're taking these patients from a 6.9 or so down to, below 5, below 5, 4.7 or so. And so you're almost unenrolling them from the study if you look at inclusion and exclusion. And then the symptomology on the other side, their average on this was about 65.6 on symptomology. So a pretty advanced severe case. And you can see almost a 30-point reduction in these phase 3 clinical trials, taking them from 65 down into the 30s. So making them less symptomatic as well. And this is just another way of looking at the total corneal fluorescein staining. Instead of at 8 weeks, we're looking at it at day 57. I already gave you kind of those averages. 6.9 is the average in the phase 3 clinical trials. You can see 2.2 at day 57, which was their primary endpoint. So this was about 8 weeks. So about a 2-time improvement in their total corneal fluorescein staining on the data side of this. And then safety and tolerability, I think, Kendall, you and I would both agree the times that we prescribe this, you don't really have a lot to worry about from your patients from a standpoint of, boy, they're going to let you know that things are uncomfortable, because it's very, very well tolerated. There was minimal adverse reactions. You could see one patient discontinued out of the whole study. 600 some patients in this particular study, or 600 some patients actually got perfluorohexyloctane in those phase 3 clinical trials. And then the most common thing was a little bit of blurred vision. But I think that was like 13 to 16 patients only out of those 600 or so patients that were on perfluorohexyloctane. So very, very well tolerated from a safety standpoint. So kind of concluding this was my patient, and wanted to just share the video with you of heating and then my clearing of the glands in this patient. And that is such a satisfying thing when you heat the glands and then that happens. You're making an impact. I can't get enough of it every time I see it.
Justin, I think you have to be careful where you show this video. Okay. Oh,
We're just showing this to all doctors, right? We all feel
that's
pretty good about this, right?
impressive job. Well done.
And so just getting the glands, cleared out. And then of course the treatment doesn't stop there. You do this and then we need to move on to the other things. And so, This is just showing some data around external heat and manual expression, a 15-minute thermal eyelid treatment. Then you manually express the glands like you saw I did in that particular situation. This is a small N study of only 29 patients, but there were significant improvements in signs and symptoms of dry eye, in really all the patients in it. And a big percentage of these patients had meaningful symptom relief. This was my patient. She also had very meaningful symptom relief. She said her eyes felt much better. Her vision seemed better. Her visual acuity improved, 20/20 in both eyes. You can see MMP9 actually tested out negative, which doesn't always happen, but in our case here, it did. And her osmolarity improved. Now, based on our question earlier, osmolarity is still abnormal. It's greater than 8, but it's an improvement. That number is lower, but still considered abnormal. So there's still work to be done. And you can see the slit lamp exam, all of those things looking better as well. The cornea had cleared up, and a much, much happier patient in just 6 weeks. And now it's going to be, how do we maintain and manage this particular patient? So, final question. According to the Olympia trial, office therapy with thermal pulsation and thermal therapy with meibomian gland clearance improved a patient's ocular surface disease index score, and this was on average in this particular study, from 52.29 and 51.1, which is a severe level on the OSDI, to A, a normal level of 8.1 and 7.1, B, a mild level of 18.1 to 17.1, C, a moderate level of 27.7 and 24.16, or D, a severe level of 42.21 and 40.21. I got a little specific, Kendall, with all the 0.29s and 0.1s. I probably could have rounded it up or down, but being a little bit of a data nerd, you kind of leave it alone.
That's tough, Justin.
So the answer on this one is C, moderate level. So, I mean, when you think about it, I mean, obviously we'd always want our patients to go from that severe level to normal. But I'd love your thoughts, Kendall. I mean, taking someone from severe to even moderate, I mean, that's significant in my mind. Well, I just want to thank you for taking the time to do this with me, Kendall. I had a blast. What a fun conversation around all the different treatment options. So I really appreciate it. I want to thank everyone for taking time for joining us. I know never easy if you're doing this, during a clinic day or busy clinic day or after a busy clinic day. And so thank you for taking the time, and make sure you claim your CME and CE credits. And I'm excited to do part 2 with you, Kendall, because we're going to have a few more interesting cases.
Sounds great. Thanks, Justin.